Good morning and good afternoon, everyone. My name is Marlene Mwanga. I'm the Knowledge Management Specialist for the SIAPS Program. Thank you for joining us today. We are delighted to see so many participants from around the world. Today's webinar will feature a 15-minute presentation on SIAPS pharmaceutical system strengthening work in two countries, Mali and Ukraine.
Hi, my name is Luis Ortiz. I'm the Manager for Knowledge Management and Learning. After the presentation, we will have a live question and answer session with our presenter and other SIAPS staff who will be available to answer your questions directly. Marlene and I will be the moderators for this webinar. We will only be collecting questions through the web chat feature. You can write in your questions at any time during the presentation.
Great, thank you, Luis. Without further delay, let's begin our presentation.
Hello, my name is Kofi Aboagye-Nyame and I'm the Director for USAID's Systems for Improved Access to Pharmaceuticals and Services, or the SIAPS Program. The SIAPS Program builds on decades of investments in improving pharmaceutical management in low and middle income countries to improve health outcomes. Pharmaceutical systems, like health systems, are composed of complex and interconnected structures and stakeholders. The patients, family, and community health is at the center of an extensive network of healthcare providers, ministries of health, healthcare administrators, civil society organizations, universities and training centers, governors, donors, and other stakeholders. Every day, these healthcare leaders and frontline workers make life-saving decisions about patient care and treatment, and to do so, they require access to timely, quality, and reliable data. SIAPS is a USAID-funded program that uses a system-strengthening approach to build pharmaceutical management systems to improve access to and use of pharmaceuticals in over 45 countries. We approach our work using the framework that we call the DAISY Wheel that guides the design, implementation, and monitoring of pharmaceutical system strengthening activities. In partnership with local governments, with other donors, healthcare providers, and communities, SIAPS analyzes and considers the interactions between all the core health system strengthening functions and the medical products building block to design interventions to improve pharmaceutical management and service provision. Across SIAPS country programs, lack of accurate, reliable, and timely information has created barriers to effective decision-making about pharmaceutical service delivery and provision. SIAPS has approached this challenge by working closely with stakeholders to improve information management systems. This makes it possible to collect, organize, and analyze and present data which facilitates timely and informed decision-making. For effective decisions to be made for the long-term health impact, data must be available and also appropriately used. In this webinar, you will learn how two countries supported by SIAPS, Mali and Ukraine, address the challenges that prevented the availability of quality, timely, and accurate data. With access to data, ministries of health and healthcare providers make informed decisions about the allocation of pharmaceutical resources, specifically what is needed, where it is needed, when it is needed, and how much. Now let's start with Mali. SIAPS has been working in Mali since 2011. Until recently, the pharmaceutical information system in Mali was paper-based and required manually compiling and aggregating data from over 1,000 facilities. Some of the main challenges related to this included a lack of up-to-date and reliable pharmaceutical information, poor coordination among key actors resulting in avoidable delays in critical supply chain related decisions, which has led to frequent stockouts of essential medicines. To meet these challenges, SIAPS has taken a holistic approach that has entailed understanding the country's unique needs and requirements, building local capacity to ensure country ownership and sustainability, and establishing tools for data collection and aggregation such as OSP Sante. Let's take a closer look at one of our more innovative platforms for data collection and use, OSP Sante. So what is OSP Sante? This is a web-based dashboard that provides near real-time patient and commodity information for public health priorities such as HIV, malaria, maternal and child health, and family planning programs. OSP Sante has important benefits, including improving planning for medicines distribution and prediction of stockouts, easier collation of patient and commodity information on one platform, enhanced data analysis and reporting, and easy and timely access to data and reports. So how does OSP Sante work? First, on a daily basis, data is generated by health facilities which deliver primary health care and are staffed by healthcare workers such as physicians, pharmacists, and nurses as part of their routine work. On a monthly basis, the data is sent to the district level where it is validated and entered into OSP Sante. Once in OSP Sante, the data is now used to generate reports that are used for decision making. For example, at the national level, a formal committee chaired by the Minister of Health that includes the directors of all health programs such as malaria, HIV/AIDS, Ebola, MNCH, and the director of the Central Medical Stores meets regularly to analyze data from OSP Sante. At these meetings, recommendations and decisions are agreed upon and actions taken. So what does this mean in terms of data availability and appropriate data use for the long-term health impact? On data availability, a challenge often faced by Ministry of Health officials and their partners was the lack of data at coordination meetings. Prior to OSP Sante's implementation, decisions were often made based on assumptions rather than data. The logistics data reporting rates improved after the intervention of OSP Sante, making data visible and accessible. The percentage of health facilities that completed and submitted an LMIS report increased from 40 to 98%. On data use, in Mali, more effective use of data led to better coordination. For example, as a result of reports from OSP Sante, the Ministry of Health was able to move commodities from one region to another in order to prevent stockouts. Data has also been used to make important decisions about the allocation of resources. On impact, due to the availability and use of data across the country, we see a decrease in stockouts of health commodities. Now let's take a look at Ukraine. SIAPS has been working in Ukraine since 2011. Ukraine is the second highest TB-burdened country in Eastern Europe and also has a severe HIV epidemic. The Ministry of Health of Ukraine requested technical support to address a number of systemic challenges related to TB management. In 2013, an assessment identified a number of challenges Ukraine faces in regards to pharmaceutical management and in particular control of TB and HIV. These included poor tracking of MDR-TB and TB-HIV co-infection, a weak system of demand forecasting for medicines, a lack of integration between TB management in the penitentiary system and the rest of the country. The prison system constitutes over 15% of all TB cases nationwide. In short, the information management system required radical improvements in order to support planning, managing, and decision-making about the control of TB. To meet these challenges, SIAPS took a holistic approach that included the following. First, SIAPS worked with the Ministry of Health to implement eTB Manager to manage TB-related data. SIAPS provided computers, internet connectivity, and addressed issues of information security. SIAPS also trained users and generated evidence for eTB Manager's use across the country. Eventually, the Ministry of Health and the National TB Program issued an order making eTB Manager the national data collection tool for TB. Let's take a closer look at eTB Manager implementation in Ukraine. eTB Manager is a web-based tool for managing information needed by national TB control programs. It integrates data across all aspects of TB control, including information on suspects, patients, medicines, laboratory testing, diagnosis, treatment, and outcomes. In Ukraine, ETB Manager has been adapted to include all the key components of the Ukrainian National TB Program for the management and treatment of TB patients across the country. But how did it work? How did Ukraine achieve national coverage of its TB program? SIAPS, working in collaboration with national stakeholders, took a phased approach to addressing the data for decision-making problem in Ukraine. In the initial phase, implementation of ETB Manager began in 2011, and the number of cases entered increased from 5,000 to over 15,000. Implementation in the penitentiary system started in late 2011, and for the first time, patients could be tracked in both the penitentiary and public health systems. In compliance with Ukrainian legislation on information security, security certification was obtained for ETB Manager. Lastly, there was a ministry order on the use of ETB Manager nationwide. This started a new stage of implementation, Phase 2. By 2013, all regions across the country were entering cases into the system. By 2015, over 185,000 cases had been entered. A data quality assurance protocol was established and determined a high level of consistency between paper-based and electronically generated reports. Having comprehensive and accurate data and a quality assurance protocol has been critical in improving the data available to support decision-making in Ukraine's TB program. In Phase 3, SIAPS continued conducting training of trainers and training for users to ensure the smooth transition of ETB Manager to the government of Ukraine. As of now, SIAPS has completed a technical handover of ETB Manager to the Ukrainian Center of Disease Control. Next, I will briefly share what resulted. In terms of data availability, in August of 2015, there were a total of 185,760 cases in the system. The consistency between paper-based and electronically generated reports reached 90%. The nationwide implementation in Ukraine is exemplary. All 25 regions are regularly reporting at least 95% of new TB cases in ETB Manager. And in terms of access to information, TB doctors and other health workers are able to quickly retrieve patient treatment history, thus saving time. Time spent finding and keeping track of treatment cards and paper documentation has been drastically reduced. On data use, for the global fund planning purposes, with the help of ETB Manager, UCDC has been able to accurately estimate the number of medicines needed to manage side effects. In the past, there was no way to retrieve patient history when a patient showed up at another health facility. With ETB Manager, health workers are able to enter the patient's name in the system and retrieve the diagnosis and treatment history, including other health facilities previously visited by the patient. When it comes to the impact of the system, currently, over 185,000 patients have their records in ETB Manager, allowing for better control of TB treatment and detection. For example, this has allowed for cases of treatment, default, and repeated application for medical care to be tracked, avoiding violations of TB treatment standards and monitoring of irrational use of TB regimens. For example, this has allowed for cases of treatment defaults and repeated application for medical care to be tracked, avoiding violations of TB treatment standards and monitoring of irrational use of TB regimens. In a user satisfaction study conducted in 2015, 82% of users agreed that their workplace productivity improved because of ETB Manager. For example, ease of access to information has mitigated the need for repeat phone calls, emails, or office visits among health providers. In conclusion, Mali and Ukraine are two of the over 45 countries supported by SIAPS. In both of these examples, data availability and use have significantly contributed to the country's national and long-term health priorities. OSP Sante and ETB Manager are two examples of innovative platforms used for patient management, data collection, and use that have improved the ability of stakeholders at all levels of the healthcare system to make informed decisions about the allocation of resources and management of their pharmaceutical systems. For more information about SIAPS work, please visit our website www.siapsprogram.org and stay tuned for more updates on how SIAPS is strengthening pharmaceutical systems. Thank you.
Thank you for the presentation, and thank you to all the participants that have commented and sent questions so far. Joining Kofi today, we are also delighted to have two SIAPS Principal Technical Advisors, Seydou Doumbia and Naranjan Konduri, who will be joining us for the question and answer session. Seydou and Naranjan bring hands-on experience with ETB Manager and OSP Sante. Kofi, before we get started with the questions, would you like to make an opening statement?
Yeah, thank you, everybody. Good morning, good afternoon, good evening, wherever you may be in the world. And thanks again for taking time to join us. OSP Sante and ETB Manager, along with other tools, have been adapted, implemented, and used in a number of the countries that the programs have been supporting using USAID funding over the past few years. The links on the screen will take you directly to the SIAPS homepage, where all our web-based tools and other tools can be accessed. There are many details that I could not include in this short presentation. However, we are looking forward to answering your questions about these tools and other experiences that we have gained supporting data-informed decision-making in pharmaceutical system strengthening. So feel free to type in your questions, and we are here to respond to them.
Great, thank you, Kofi. Again, yes, please do submit your questions through the web chat. So let's begin with our first question. The first question, given that evaluating the quality of data at the facility level often requires a great deal of effort, how are SIAPS tools equipped to recognize inconsistent data trends and raise flags for targeted inquiry? Kofi, would you begin?
Well, certainly, in developing the system that manages tools and manages information and data systems, what we do is to ensure that we have a comprehensive data quality assessment system built into the whole system. So it's not just about the tool that is being implemented, but the systems that are in there to regularly validate, to regularly check in to see whether the information that has been captured is actually along the lines of what is expected. We also, at the beginning of the program, typically run a parallel process where we would have the paper base going alongside the electronic system for a while. And so during that time frame, we would be checking to see the consistency between the paper and the electronic based system. Beyond that, then we would move into a phase where we would ensure that we have moved 100% or a certain degree of percentage into the electronic system. But on a regular basis, we have to go back and through our monitoring and supervisory visits, check in with the consistency between the data captured, the analysis done, and the actual facts on the ground.
Great, thank you, Kofi.
Thank you. So for our second question here, has SIAPS quantitatively evaluated its tools for their impact on improving data quality for intended outcome? And if so, what were some of the main findings from this evaluation?
Yes, in our Ukraine TB program, we do a periodic assessment of the data quality and to ensure that we have some of this information. And I'll ask Naranjan to give us some more update on that aspect of the work.
Thank you, Kofi. Initially, when the Ukrainian Center for Disease Control took over the nationwide rollout of ETB Manager, one of the measures that they needed was confidence in data quality. And the way they accomplished that was to have regional teams of supervisors who worked with oblast level or province level supervisors, So that collaboration between the national authority and the state level authority was the first step, because state level authority had their oversight for their state level data quality aspects. And the first step they took was to compare basic paper records with the data entered in ETB Manager, and they were able to systematically implement this data quality check in every state in Ukraine throughout the whole country. And when they had the statistics from each state, when they compared paper-based records with data entered in ETB Manager, that information allowed them to track poorly performing sites and track examples of high performing sites, and they created a knowledge exchange series within Ukraine itself, and which allowed supervisors from low performing districts to learn from high performing districts as to what were the strategies to motivate healthcare workers, or what has been the information flow process that may have facilitated the data entry into ETB Manager. And this kind of data exchange between different supervisors facilitated by national authorities significantly adopted the process with data quality check. And the other aspect that facilitated this success was publishing the results of this data quality check onto the National TB Program website. And as a result of that, each state would see the name and the results for the results of the data quality check, and that served as a sort of a motivation for high performing districts compared to low performing districts who needed examples to look up to.
Great, thank you, Naranjan. And we have a question from our participants on specifically about Mali. The question is, I know that the Global Fund is pushing towards integration between DHIS2 and LMIS. Have you worked out in Mali how this kind of integration is happening? Sadie, can we direct that question to you?
Yes. Thank you. That's a very interesting question and very important question. Yes. In Mali, we are now presently, as I speak, a team on the ground in Mali to work on the integration between DHIS2 and OSP Santé. And what we are planning to do is that to have a kind of interoperability between the two tools. How is it going to happen? First of all the data are presently captured in OSP Santé. But going forward, we want DHIS2 to roll out to all the country. All the data will be captured in DHIS2, and OSP Santé will going to take the data from DHIS2 and to visualize it at the first step. At the end around, everything will go to DHIS2 to be able to include the LMS function in DHIS2. That's possible. You did it already in Bangladesh, and our team is working on it now in Mali. And that has been required by the country, and we are working on it to make it happen. Technically, it's possible, and also we are planning to do it in the next coming month in Mali for DHIS2 interoperability with OSP Santé.
Well, just to talk a little bit more about that, and in addition to OSP Santé and DHIS2 in Mali, in a number of the countries that we also work in, we are actually looking at integration with DHIS2. So, for example, in Bangladesh, the web-based dashboard for our LMIS is also being integrated with DHIS2. In Kenya, our health commodities management project is also working on integration of some of the work in DHIS2. And we are currently also pursuing a project in Guinea where we are looking at integration of the ELMIS program that we are yet to implement also into DHIS2 as a way of conforming to where everybody is moving towards now.
Great, thank you, Kofi. I have another question from a participant, Hazel Bradley from the School of Public Health at the University of Western Cape in South Africa. And this question is on ETB Manager. Is the ETB Manager linked to other databases, for example, HIV/ART?
That's a good question. Now, originally, when ETB Manager was developed, it first started in Brazil. And it's important to provide a historical context in relation to the question about linkages of data to HIV programs. And because about 10 or 11 years ago, many countries, such as Brazil, were confronted with the reality of expanding care for MDR-TB, which was highly centralized for multi-drug resistant tuberculosis. And as a result of that, there were severe information needs, and within those constraints, the focus was initially just on multi-drug resistant tuberculosis, MDR-TB, And over time, the ETB manager was customized to allow data entry for drug-sensitive tuberculosis, as well as fields for different comorbidities such as HIV. And now, depending on the country where the request was made to link data for HIV/AIDS programs, those customization was done at country level. So, for example, if in a district facility in Namibia, where ETB manager has been used, if they needed to provide care for MDR-TB patients, and that patient comes from an ART program, antiretroviral therapy program, then that person would come with a patient ID and the name, and that information would be provided to the health worker, who would then look up the patient data from the HIV program and then enter the treatment history from that was provided to the health worker by the patient's doctor into ETB manager. So as a result, if there are patients suffering from both TB and HIV, both the information would be available in ETB manager. So a lot of it would be dependent on information flow that was provided to the health facility worker. Now in the long run, ideally, yes, we would like to technically link ETB manager with databases that are tracking HIV/AIDS patients, but we haven't gotten there yet because a lot of it depends on country circumstance, the level of collaboration between disease programs, the infrastructure, and the information exchange ability, such that the two systems are talking to each other or not. Thank you.
Great, thank you, Niranjan. And I have a follow-up question, actually, on ETB Manager. How has the implementation of ETB Manager been affected by the unique political and social changes in Ukraine?
Oh, good question. We get that a lot. As you may recall, when Kofi mentioned in his presentation about the Ministry of Health order, it's easier said than done, because after the pilot phase in the years 2011-2012, it gave substantial confidence to the central authorities at the Ukrainian Center for Disease Control, and they realized that it was in their best interest to secure the information flow as soon as possible through ETB Manager. So they began advocating for a mandate. And in Ukraine, a policy may not work, but an order works, and that was necessary to be done through the Ministry of Justice. And much before the Maidan revolution in December 2013, we managed to secure with the Ministry of Health the order mandating that the whole country, all TB programs, all health facilities that may not necessarily be a designated TB facility, but even if they are general hospital but may be seeing TB patients, they are required to use ETB Manager. And that was highly effective. And the program director for the tuberculosis program was quite relieved that we managed to secure the order, because otherwise during the Maidan revolution and potential government changes, there were a lot of uncertainties with change of leadership and the fact that we may have had to start all over again. And that was a significant factor in making sure that we reached our goal together. Thank you.
Thank you, Niranjan.
Thank you. So we have another question about OSP Sante in Mali from Samuel, who's joined us from Kampala, Uganda. What were the technical challenges in rolling out OSP Sante in Mali, and how did you achieve such a high level of adoption and compliance?
Thank you very much. That's a very interesting question. Technical challenge for OSP Sante. Since you begin with only challenge you have was the internet connection at the very beginning. So Mali is a very big country. You don't have internet everywhere. So you succeed to fix this solution by providing internet key to all the health districts. For example, OSP Sante is used in 50 districts in Mali out of 60. So in addition to that, also you develop also an offline version. If there is no internet, you can just capture the data on Excel and upload it to the tool once you have internet. But that has been fixed now. You don't have any problem in this already now, as I speak. How do you achieve such high adoption appliance in Mali? That's very interesting. I think it depends on the approach. What was very important in Mali, that's the approach. What we did, we didn't bring the tool to Mali, say, here's the tool, we are going to train it and use it. No. We worked with the stakeholder to develop the tool. And how you did it? What we call a system study visit. We did in Mali 2 visits to study the system, to go to a health facility and to define the problem and bring a solution to them. We want to collect everything together, develop a tool and present to them to give them the opportunity to be involved on the first side of the tool. That has been very, very helpful. And then we start rolling out in the country to do a training for trainer, do a training of user, and also every quarter, you have every quarterly meeting to review the data generated by the tool, to review the report by the tool, and to give the opportunity to a stakeholder to provide some kind of input to the tool. I do say the success for that is the approach to involve the stakeholder at the very beginning. That has been very effective for implementing the tool.
In addition to that, our experience in obtaining high adoption and compliance also relates to how the end users of the tool see their work being enhanced because of the information and the data that they can readily access. In Bangladesh, for example, when we launched the web-based dashboard, the Minister of Health who launched it was very pleased to see that he could see a district, he could see an Upazila in there, and if there were issues, he could highlight and know the person there and the phone number. And so once we get high-level political interest, and once we also get the technical people using the data, then it becomes important to maintain it, because somebody can. In a recent discussion with one of the partners that we work with, he was very happy that now in Mali he can go online and see where there are stocks and where there are no stocks. And so just the fact that other peers are looking at the data allows other users of the system to want to maintain their data and to be accurate.
Great. Thank you, Seydou, and thank you, Kofi. I have a question for all three of you. What has been SIAP's experience in transitioning tools like OSP Sante and ETB Manager to ministries of health and local governments to ensure that they continue to support responsive and resilient health systems?
How's that? I think that our experience has been very varied, and in the number of countries that we've been working over the past years, we've had several tools that we've developed with the countries that we eventually either 100% transition or are in the process of finalizing that transition. In Namibia, for example, with several iterations of US government support, we've developed some tools, including some medicines registration tools and an essential HIV/AIDS medicines dispensing tool that we call EDT. We eventually 100% transitioned the management of the tool to the pharmacy department of the government of Namibia, and it was a very smooth transition. But it was because throughout the development, as Seydou referred to, we had been working with the staff of the ministry to ensure that everybody who was working on it had access to how to use it. One of the other features in the Namibia example was the development of the tool was also done using local expertise, not all the expertise coming from the US. So the IT firm that is overseeing and managing the tool is also local. So when it came to managing it locally, it became much easier for the government to take and manage it. In other countries, we've adopted a similar approach in transitioning it. And so with South Africa, for example, we recently transitioned the RX solution, which is also a dispensing to the government. We handed over the source codes to the government, and they are in the process of establishing a process to be able to manage it on their own. So working with the governments, the experiences have been different. One of the key challenges we've had is getting governments to budget for the maintenance, especially of the hardware, and also maintaining the internet connections and the support to the server situations. So we've had several alternatives where we've been working with the government to ensure that prior to the end of our program, this information, the transition plan, what it takes to own and manage the tool, the costs, the human resources required are always discussed up front so that governments are aware of what it takes and what they need to do. We are currently in the process of discussing with the West Africa Health Organization to be able to transition another tool that we've been managing in West Africa, ospcida.org, to the West Africa Health Organization. So the process is helping WAHO to establish a team of people that will be trained and with the capacity built, the servers built up to be able to take up and manage it. The key thing of handling these products over is not just handling the tool over, but also building capacity of the government systems to be able to provide the oversight and the follow-up to ensure that the data quality is maintained. I'll let my colleagues also chip into that.
For Mali, for hospice Santé, I think Kofi covered everything about that. But particularly in Mali, what was really easy to hand over the tool is the process. As I said at the very beginning, the pharmacy division was the owner of this tool, as you've seen at the very beginning, and SIAPS is providing technical support. And in this way, I think it is so easy to handle them. And in addition to that, if the tool is really needed for the country, users are thinking that the tool is going to fix their problem. It is really easy for the handover. As I speak right now, I mean, we are in handover process in Mali, and it is really owned by the government. They took the ownership in the very beginning, and they are using the tool around all the country. I just want to mention that SIAPS Santé is the only national tool adopted by Mali government to report on community vulnerability in the country for all diseases, across all the diseases.
Yeah, I just have a brief point to make from the example from Ukraine, and that is to do with leadership. Once a leader sees value in any tool, any information system, and that value-added service creates a kind of platform for ability to make decisions and track performance of the program, it serves as a clear motivation. And second of all is the communication between SIAPS program at country level in Ukraine, between our donor in Kiev, USAID mission over there, as well as the national authority, because we had a 12-month notice in terms of our mandate to transition the tool, and that timeline allowed sufficient time, a period for the National TV Program Director to start looking for resources from other sources. And for example, the Global Fund money was used to sustain the use of ETB Manager, to pay for the server maintenance, to pay for internet connectivity in other parts of Ukraine, as well as a local programmer. And then the Ministry of Health themselves allocated portion of the money, realizing that SIAPS funding would be ending, and that sufficient notice did not act as a surprise. It was more than 6 months, it was a year. And second of all, the Ministry of Health also and the SIAPS program also developed, as part of the transition, a very detailed action plan in terms of roles and responsibilities. So even if the USAID SIAPS program may not have necessarily had any partial financial commitment, but a significant technical assistance component, even that technical assistance component went on a slider scale, where it was gradually transitioned in terms of the updates that was required for ETB Manager, in terms of data quality checks, in terms of any standard operating procedures that are routinely released, and that allowed sufficient time for both parties to understand where we are going with that process. Thank you.
Great, thank you. This is really a question for all of you, and specifically on Mali and Ukraine. The theme of this webinar is data to action. From data to action. So how has SIAPS ensured that decisions or recommendations that have been informed by data are actually acted upon?
First and foremost, in addition to putting these tools and making the data available, we also support governance bodies such as committees that take decisions about the commodities use, committees that take decisions about the health services that are in place. So in a number of countries that we are using these tools, the regular reports get fed to these committees who use them to make decisions. And out of that, there are regular monitoring and supervisory visits also follow up to make sure that these are also done. We've also seen a movement of commodities as a result of data that is generated from some of the reports that come from these systems. It is not always easy to directly attribute what is happening from the data that is generated from the systems and the decisions that are being made. Because once it's a web-based system and an official of the government has access to it, can log on, see the data and take a decision, that decision is not always logged or reported back into the monitoring system for us to know that all these decisions are being made as a result of this. However, the formalized channels that we know of are the regular meetings and the governance bodies that are actually using some of this data to take their decisions. However, our supervisory visits and the feedback reports that we follow up on are where we make sure that the data is actually being acted on. Again, Countries are also using some of this data as part of their quantification and forecasting efforts. They are also using some of this data to determine when commodities should come in and when commodities should be held or diverted for some other purposes. And we have examples of this across the programs that we've been working in.
For instance, in Mali, you just completed the MCH cumulative quantification, and before all the quantification data was difficult to generate it. But during this quantification, you use OSP Santé data to do the quantification of MCH cumulative based on consumption. That is very important. As Kofi has said, they have many committees in Mali. They have national committee, regional committee, district committee, and they have a meeting, regular meeting on a quarterly basis, and all of them use OSP Santé data to make some recommendations based on community availability. And some of the recommendations may be moving drug for one district to another district, and how we assess that is through supervision. The other thing also help us to make sure the recommendations are implemented. And in the malaria program, for instance, they are implementing end-user verification, which is just to ensure the availability of community into the field. And through end-user verification implementation tool, you can just see that something has changed before and after the implementation of OSP Santé in Mali in terms of community availability. There are some of the ways to help us to assess the implementation of the recommendation from the data generated by the tools. Thank you.
Thank you, Seydou. While my two colleagues gave great examples at the national level in terms of how it worked, let me just tell a small story in terms of a health facility, in terms of your question about how decisions were made. I was once in an office of a multi-drug resistant tuberculosis doctor in Ukraine, and she had received a form, government form, which required her authority to release, the handover of a newborn to a patient, a mom who had just delivered a baby. And at that point, she looked at the patient's comorbidities, and the maternity hospital had sought her approval. And when she realized that this patient was a TB patient, she wanted to check if this TB patient had completed treatment, whether this patient had been taking medicines on time. And when she had her assistant log into ETB Manager to retrieve the data, at her level she has authority to look at any patient because she is the authority for the state level, which means that even she can track patients at different facilities. Not everyone has this administrative view. And she discovered that this patient had developed multi-drug resistant TB, and this person was resistant to 3 of medicines. And that information was not transmitted to the maternity hospital, who were actually getting ready to release the newborn. And as a result of this information that was available immediately, this doctor rejected that request and wrote a note saying that the newborn cannot be released until the patient finishes multi-drug resistant TB treatment and arrange for protection. Now, by contrast, if ETB Manager was not there and if the data was not accessible, I asked the doctor, what would you have done? And the doctor mentioned that, I would have had to make plenty of phone calls, because a lot of paper records are located in another district hospital, and the maternity hospital is in another section of the state. And so all of this would have added layers in terms of the number of phone calls to be made, number of follow-up, and something that wouldn't have been accomplished in a day. Could have taken a long time. Thank you.
Great, thank you very much, Naranjan and Kofi and Seydou. We have a question from the audience. Can you talk about, and this is for Seydou on OSP Santé, can you talk about moving commodities from region to region in Mali?
Okay, thank you. So OSP Santé has some kind of monthly report. You can have national monthly report, regional monthly report, district monthly report, and facility monthly report, which can present the situation of the commodity in the particular region. Is give the opening balance, the consumption, and the end balance of the commodity, and give a number of months of stock based on consumption. As you have a map across the Mali, you can just present it to see where you have stock out, where you have overstock, and where you have adequate stock. Based on this information, the decision is being made at the regional level to say, oh, look at this district, they have a high level of stock in this district. At the same time, in other district, there are stock out there. So decision is made at the regional level to move the commodity from this district to another district, or it could be from one region to another region, depending on the level of amount of stock. But all these things is based on the amount of stock available, based on consumption. If you have a consumption that are regularly tracking, you have a amount of stock available, you can just see, from the map, see where you have a high level of stock and low level of stock. You can make a decision to move from one district to another district, from one region to another region. That's what we are doing in Mali for that.
Great, thank you, Seydou.
So we have a question from another participant. Can you speak more about the challenges of changing workplace culture in ministries of health and amongst other partners to taking the time to use data for decision making?
I think the challenge is challenging, and one cannot dispute the fact that there are several issues that relate to that. And principal among these are legislation in a number of countries. Irrespective of the fact that we have an electronic tool that might be able to collect the data, analyze the data, and present the data, there might be an old law on the books that requires the government staff to continue filling some of these forms. And so in Ethiopia, in Bangladesh, in a number of countries, we've been faced with those things. And so irrespective of the fact that there's a more effective way of doing it with the tools, with the transaction tools and the dashboard, they still have to go through the process of filling those paper forms to meet the legal requirements. So that is normally the very first aspect of it. And so the question of asking somebody to fill a paper form in addition to also entering the data onto a computer system or transmitting it through a mobile system or another means becomes a challenge. So that has been the biggest issue there. But what we've also found is the fact that once these things get implemented and the use of the systems become institutionalized and people see the value, they want to uptake it and want to use it more. However, when the inputters of the data do not see any value to them and they think that somebody else is collecting the data or we are collecting that data for somebody else to use and they don't see what's in it for them, then having them adopt it becomes a problem. When they become proud of the system, I remember an experience in Bangladesh where the director in the family planning department was very proud to showcase the tool that they had, that they can see what's going on everywhere. That is when the culture change happens. But it has to happen individual by individual, convincing them that this happens. And the peer pressure also really has an input into that. But once they see that their decision making is becoming easier, or they see that their life is becoming much easier. There's an example of a hospital up in the north of Namibia, Ushakati Hospital, where the implementation of RX solution dramatically reduced the number of hours that the staff had to spend in the dispensary after the close of the dispensing window, because now the system was actually generating the reports that they had to stay in and do. So that generated a culture change that now I can go home much earlier. Now I can do a schedule for how many patients I can manage on a daily basis. So developing these systems, even though primarily we want to get the data and want to do the analysis and make decisions, one needs to take into consideration the culture, the workflows, and what is important to both the patient and the health worker who has to fill these documents. There must be a transaction tool. It must help the staff member to do his or her work. It must improve the conditions in which they are working and also at the same time assist in decision making in the process of improving health outcomes.
Great. And Seydou, we saw from the presentation that Kofi gave when he was talking about the process in which OSP Sante worked in Mali, and mentioned that before decisions had been based on assumptions and now they were made on data and the reports generated from OSP Sante. Can you tell us a little bit more about how those meetings have changed?
Thank you so much. I think SIAPS did a lot of work in Mali, putting in place all this committee at all the levels, national, regional, and district level. That's very important. Before OSP Sante, there were relying on paper-based data, which not come. It's coming late. For instance, you can have a quarter, 3 or 4 months after, or they receive information which is too late to make a decision. If a stock had already happened in such facility level, they cannot make any decision based on that. And the first quantification you did in Mali at the very beginning was only based on assumption. If you come to morbidity data, on assumption there are no real data, sometimes they send people into the field to collect data which are not accurate. So having OSP Santé report produced on monthly basis has changed a lot in terms of coordination about all the partners, because everybody has the same information. Everybody has the same information regarding the stock status. They have information about the shipping. They have all the information about the order in the pipeline. So having all the information for everybody has improved a lot of coordination for that. Before OSP Santé, you can sit in kind of meeting with no decision really based on facts. Secondly, at the lower level, at the district level, you have opportunity to have your own data. You just have to mitigate stock out ahead. And based also on the availability of information on OSP Santé, they can make a good planning in terms of supply planning, in terms of product distribution into district level. That has been really helpful. So saying that all in all, having all the information has really improved, information sharing, decision based on fact, and make a decision to be take at all the level about the donor, for instance, about the supply plan, about also the order supply system in the country. That's how OSP Santé has improved. That's only a few examples I can give for that.
Great. Thank you, Sadiq. And Kofi, would you like to add something to that?
Yes, there's something popped up on the chat about health workers resisting introduction of technology. And yes, this is something that we've seen happen a lot. And I think that sometimes, because maybe some of us are so used to technology, it's become such an integral part of our life, we overlook the fact that some of health workers that we work with may not necessarily be that comfortable. And so in the introduction of these tools, we would have to overcome that technology gap, that technology fear, by going to the basics: how to use a computer, how to start up a computer, how to use these tools within the area. There is that fear that data that is captured in electronic systems, data that is captured in the internet, is available to anybody and everybody, and the security issues that are around it. And so working to ensure that the staff understand the security aspects of it, that it's okay to use these tools and it's not going to take anything away but enhance it, and actually paying attention to the real fear is key in getting success in adoption. Because some people are not adopting it, not because they don't want it or they don't see a need for it, but they are not too sure whether they can manage it. So these are real fears that we've seen across the countries that we work in, and so we have sort of not built this thing into part of the training and introduction processes to ensure that it happens. Countries that are not comfortable in hosting their data on the cloud typically would want to opt for their own servers or servers that are managed within their countries, and we have always gone along with those ones in order to ensure that the staff and the countries are comfortable with the technology that are being introduced. But sometimes the fear of technology has prevented programs from actually introducing the technology that needs to. But I believe that with the consistent use and proving that these technologies can work, we can actually achieve a lot, and we'll continue to do that.
Thank you, Kofi. And I have one question for the three of you. How does SIAPS handle the demand for tools like ETB Manager and OSP Santé from other countries where SIAPS doesn't have current presence?
Okay.
Would you like to start?
Yes, I'll try and answer that. Currently, our tools are developed in such a way that, yes, we bring it in and we implement the tool as a comprehensive technical assistance program. One of the things we do not believe in is dropping tools, so just sending in a tool and leaving it and saying, this is how the tool works, so move along and use it. That's not been our approach to date. However, we do recognize that the SIAPS program or the U.S. government support cannot be in all countries that may have a need for some of these tools. And so we are in the process of making the number of these tools downloadable and accompanying them with enough material, guidebooks, manuals, videos that will allow countries that want to adopt them to self-start In the countries that we work, it's not much of a problem. We can provide the support. In countries that we do not have the direct support, then it would have to be that kind of assistance. Most of our tools are not in that phase now, but we are in the process of doing that. A couple of tools like QuantTB you can download and use, Quanimet you can download and use, and so we are trying to do that for almost all the tools that we have, to re-platform, to make them downloadable and available with the necessary guidance and manuals that will help countries at least self-start so that we can provide some support that is needed. But in the meantime, any support, even if SIAPS is not in the country, if the information or the request comes to us in the SIAPS head office, we'll be able to see how best we can orchestrate some support to get it started, or to guide or to advise as to how the country can begin to think through the process of adopting those technologies.
Great, thank you.
Great, so we have one final question for all of you. How might mobile technology impact data gathering in the future, if at all?
Well, we think that mobile technology certainly is going to be a way of enhancing the data capture, especially in countries where internet connectivity is not as good as the mobile penetration. We do know that mobile penetration and the cell phone usage in a number of places is much better. So yes, some of the data collection strategies that we are using actually involve some mobile technology in it. But most of the tools that we are talking about now seem to be DEX-based transaction tools that also capture data as they work in. But then when we are transmitting between locations, yes, then we think about how mobile technology can be used. In some instances, like in Namibia, for example, working with one of the mobile technology providers, I think MTN, we actually, they had the mobile technology built into our desktop tools to be able to transmit the data on a regular basis. And so where the landlines do not work, we depend on mobile technology, either as a means of transmission or actually as a tool of capture and transmission. So it has major potential in making this work.
Thank you, Kofi. Great. Well, we have come to a close for the questions and answers. Thank you, Kofi, Naranjan, and Seydou for responding to all the questions from the participants. Thank you to all the online participants as well. We have many more questions that we couldn't get to during the webinar, but I hope that we will be able to address them in future events. Thank you to our technical support with the webinar and to our web chat monitor, Olina Blasiuk. And this video and the question and answer session will be available soon on our website at www.siapsprogram.org. Thank you again.